Good afternoon, good morning, or good evening, depending on where you're watching from. Welcome to Mycoclinics from the MRC Centre for Medical Mycology at Exeter University in the UK. This is the first in season 3 of Mycoclinics, which have been going since 2021, and are 3 monthly meetings in which clinical experts from around the world present a case study with various diagnostic differentials and treatment and management considerations, including a literature review. And today's theme is fungal infections in pediatrics, and we have 2 excellent speakers lined up for you. My co-chair for this is Adelia Warris, and she will be introducing the first speaker shortly. But just briefly, these are the 2 speakers and the topic, and just to flag a reminder that all the recordings for these, as well as Myco Talks, as well as Medical Mycology Trainee Series, are available on the MRC Centre YouTube channel. And just to put a plug for the trainee seminar series, if you're either a clinical trainee or a basic scientist in mycology, this is an excellent global forum in which to present your work. So please get in touch if you're interested, as well as register to attend. Thank you very much. And I'll hand over to my co-chair, Professor Warris.
Thanks, Tihana, for that. And it's a huge pleasure to introduce to you today the first speaker, Emmanuel Roilides, who is a professor of pediatrics and infectious diseases in the Aristotle University School of Medicine and the Hippocratian General Hospital in Thessaloniki, Greece. Emmanuel and myself have worked together and are working together in the European Pediatric Mycology Network, as we are both pediatric mycologists. But his research focused on serious infections in neonates and children, among which fungal infections. He has published extensively in this field, and he is a well-known expert in pediatric mycology. And he will discuss with us a case today about neonatal candidiasis.
Okay, thank you very much, Adelia, for this very nice introduction. And let me start. We have to discuss a neonatal candidiasis case. Before we start, I would like to have 3 short questions for the audience to vote. So the question 1 is, how frequent invasive candidiasis in the extremely low birth weight infant, that is less than 750 grams, according to their impression? Is that less than 1%, 2%, 5%, or more than 10%? Please vote. How long are we leaving for answers? Okay, so most of you, 40%, said 5%, and a quarter, more than 10%, another a fifth, 2%. I think you are right. Depends on what center you are in, working in, but it is probably more than 5%, 5 to more than sometimes more than 10%. So definitely not less than 1%, not 2%, those very little babies. So let's go to the second question, which is an introductory question again. Let's see. Okay. So which is the most, 1 second. Which is the most frequent Candida species causing neonatal candidiasis, you think? Candida albicans, Candida parapsilosis, Candida glabrata, Candida tropicalis, or Candida auris? Please, again, vote. We have 5 different Candida species. which one you think is the most frequent one? I guess in different parts of the world, but might be differences. But what do you think is the most frequent one? Okay, Candida albicans, 3/4 of the respondents are Candida albicans. Candida parapsilosis was the second one, which is right. Well, in some places it might be the first one. Very little said that actually none Candida auris. Yes, you're right, although it's increasing species. But you are very right. Candida albicans first, Candida parapsilosis the second one. And let's go to the third question. Which is with what antifungal agent? This is a little more difficult. With what antifungal agent would you treat hematogenous Candida meningoencephalitis in a neonate? With fluconazole, with voriconazole, conventional amphotericin B, liposomal amphotericin B, or micafungin? Please respond. Okay, so most of you prefer liposomal amphotericin B, which is right, and also some of you micafungin, and also some of you fluconazole, which is also right. So especially if you know that the isolate is sensitive to fluconazole. Good. So let's now go to the case report. So we have a premature baby. Very premature one with the gestational age of 27 weeks and 1 day and birth weight 1,190 grams. At day 3, he started to get fed with formula. At day 17, he developed necrotizing enterocolitis at the stage of 2 of Bell. He got emergency surgery to resect the necrotic bowel, which was a large part of it, which was resected. And also at the same time, a Hickman central venous catheter was inserted in order to have fluids and actual nutrition. Antibiotics were started, gentamicin plus metronidazole, because of this surgery. And so now we have a baby with colostomy and a short gut in its place. At day 25, clinical signs and laboratory indices indicative of sepsis were developed. Was a blood culture that grew Staphylococcus aureus, which was susceptible to oxacillin. So in response to this development of bacteremia, catheter was removed, and the antimicrobial treatment was started with cloxacillin, which was added to the previous regimen of gentamicin and metronidazole. A new Hickman catheter was placed a couple of days later, and total parenteral nutrition was started, containing also lipids, of course. This NICU does not use fluconazole prophylaxis in high-risk neonates. However, it does use, but this infant did not receive antifungal prophylaxis. So the question to you, which you don't need to respond, by any means, just think about it and give your response to yourself. Would you give antifungal prophylaxis from the beginning to this infant? Yes or no? This is a baby, 1,190 grams, 30 grams, and with this first cause of bacteremia. So the answer is no, and I would say that antifungal prophylaxis against Candida in neonates, of course, the neonates which are at most risk for developing invasive appendicitis are the extremely low birth weight neonates, those which were less than 1,000 grams, and in institutes where the incidence of invasive appendicitis is more than 2%. So in addition to the general infection control and prevention measures, the standardized central line care, antibiotic stewardship, you also give antifungal prophylaxis. By what? By fluconazole, 3 to 6 milligram per kilogram twice or 3 times a week, per os or intravenously, for 6 weeks or until discharge from the NICU. This is, of course, is based on local Candida epidemiology, on MIC and resistance data, and of course, you may have, as a result of this practice, a possible increase of MICs of Candida in your unit. This practice, however, results in significant decrease of colonization, which is the first step to develop candidemia, and incidence and mortality which is due to invasive candidiasis in those very little babies. Other practices like nystatin or bovine lactoferrin probiotics are not as well studied and recommended. However, we should remember that in some places of the world, Candida auris has become a major isolate in the neonatal ICU, and Candida auris is universally resistant to fluconazole, so the fluconazole chemoprophylaxis might not have any effect on these NICUs. So at day 38, the infant presented clinical deterioration again with fever and an increase in C-reactive protein. He was not receiving antibiotics at the time, and blood cultures were obtained. And the question to you again, for your thought, you don't need, of course, to respond in either by chat or anything. Is empiric anti-infectious treatment recommended? If yes, what agents? Anti-gram positives, anti-gram negatives, anti-anaerobes, or antifungals? So one could say anti-gram positive and gram negatives. One may say also anti-anaerobes, or one can say all of them at the same time. Well, what we did was prescribed antibiotics having these activities against gram positives, gram negatives, and anaerobes. Remember, he had, the surgery in his in the necrotic necrotizing enterocolitis, which caused the resection of the bowel. Maybe you may think also an antifungal is needed, but at this point, the antifungal was not added. So the patient, the neonate, received meropenem plus vancomycin. The baby was not worsening, but still C-reactive protein was high and platelets were low. At day 41, which is 3 days later, blood culture grew yeast. One could think that maybe antifungal could be added 3 days before, but at this time the yeast grew, and as you imagine, yeast in the neonates is most frequently Candida species, but it might be also some rare species of some other rare fungi like Trichosporin, Malassezia, or Rhodotorula. Do we have any early biomarkers for candidiasis? So we may be helped that they give antifungal agent early enough. Well, as you probably know, there are biomarkers like beta-glucan, PCR, T2 Candida, and Candida antigen antibody. In older children, in more than 3 months of babies and patients in general up to the adolescence, with concern for invasive candidiasis, T2 Candida alone or in combination with platelet Candida antigen plus may be beneficial for rapid detection of Candida species. But this is again a neonate, and we don't know. We have some data for beta-glucan in neonates. There was a recent meta-analysis of 8 studies in a large number of participants, almost 500. At the threshold of 80 picogram per ml, the sensitivity was 89%, the specificity 60%, and when the threshold was 120 picogram per ml, the sensitivity was 81%, and the specificity was better 80%. So it's something which might be of value. So management, yeast in the blood, what should we use? Which empirical antifungal therapy will you recommend now? Ampho-B, deoxycholate, the conventional amphotericin B, liposomal amphotericin B, fluconazole, carfofungin, or micafungin. Think about that. You don't need to respond again. So the baby was started in liposomal hepatitis B. He had some borderline renal function and concerns about CSF penetration. So, and 2 days later, 5 days from the time that the culture was taken, Candida parapsilosis was identified in the blood. So Candida parapsilosis. So should hiccup be removed now immediately? Which antifungal agent do you prefer to continue with? Here I show some recommendations, recently published recommendations, which are most of us use. Amphotericin B deoxycholate can be used 1 milligram per kilogram once a day, cheap, less nephrotoxic in neonates than in adults. Actually, I think that it is the only place that deoxycholate amphotericin B is used in Europe, for example, or North America. Liposomal amphotericin B can be used 2.5 to 7 milligram per kilogram once daily, which is less nephrotoxic than adults, but low levels in renal tissue if you talk about urinary infection. Fluconazole, 25 milligram per kilogram per day as loading dose, day 1, and followed by 12 milligram per kilogram per day once daily in settings with low azole resistance rates. However, in places where fluconazole resistance is high, of course, you can't use it empirically. And micafungin, 10 milligram per kilogram once daily, which is high dose, is less toxic at second-line treatment. But we will talk about CSF treatment afterwards. Caspofungin, 2 milligram per kilogram per day, equally can be used. Duration for candidemia, 14 days after the first negative blood culture. Of course, you have to remove foreign bodies, catheters, and all other foreign bodies. I have some resistance data here. This is not only from neonates, but also from adults in Europe. And you can see that fluconazole resistance of glabrata, of parapsilosis, high, 13%, 19%, whereas the echinocandin rates of resistance are low, 1% up to 3% at most. Here are some data from Denmark, very, very good data, published relatively recently in 2019. And if you go to the lower part, you can, let me use the pen, there's a pointer, yes. So if you see the candidemias from neonates between earlier time and later time, you can see that this is parapsilosis. So most frequently parapsilosis is in this. Sorry, albicans. Albicans. This is albicans. There is a little trend of less albicans and increase of other species of Candida, more rare species of Candida, and the fluconazole resistance rate goes somewhat up from earlier time to later time. Okay, at the mortality rate of 17%. And these are data, also very, very recent data, published in 2023 from low-middle income countries. You can see the 4 most frequent species of Candida causing candidemia: albicans, parapsilosis, auris, and other Candida species. The middle column is fluconazole in all these panels. And you can see that with Candida albicans, parapsilosis is mostly, fluconazole is mostly green. That means that it is sensitive. Albicans is mostly sensitive to fluconazole. But when you go to parapsilosis, you get a lot of red color. So you get a lot of resistance to fluconazole. And of course, when you go to auris, most of it is red, most of it is resistant to fluconazole. So let's now see what we additional things that we do it. There was a lumbar puncture performed actually the next day, and the CSF revealed 150 cells per microliter. So we got meningitis, septicemia, phangemia, and also meningitis. This is from an old study, but it shows that meningitis with brain abscess, so CNS infection is relatively high. It's about 20% in following phangemia. So it's quite frequent. So we have now central line associated bloodstream infection together with meningeal involvement. 20%, as we said, of candidemia cases are followed by CNS infection. So the question is now, which is the most appropriate CNS candidiasis therapy? Which antifungal agent would you prefer? Azole, liposomal amphotericin B, echinocandin. So think about those three choices, and I will show you recommendations from IDSA guidelines, quite old now, from 2016, that they recommend deoxycholate amphotericin B, liposomal amphotericin B, and for step-down treatment, fluconazole at 12 milligrams per kilogram per day for susceptible isolates. Therapy should continue until all signs, symptoms, and CFD radiological abnormalities if present resolved. And of course, devices like drains, sands should be removed if possible. Now, the ECMM guidelines, which are actually at the last step to be published, they recommend micafungin 10 milligrams per kilogram per day. In day one, actually 15 milligrams per kilogram, and liposomal amphotericin 7.5 milligrams per kilogram per day. So liposomal amphotericin B was continued. Blood cultures obtained on days 40, 43, and 46. Baby was stabilized, and labs were stable or even better. However, day 46, 8 days after the start of liposomal amphotericin B, candidemia persisted, blood culture was still positive. So what can we do now? Remove the Hickman catheter, change the antifungal, if yes, which agent to choose? Is lock therapy appropriate in this case? This is something that those questions are really important. We have to respond to them. Could other diagnostic tests be helpful to detect fungal dissemination, for example, heart echo or eye examination or new lumbar puncture? Why candidemia persists? Well, let's talk about removal of the catheter. When you have shock conditions, you have to remove catheter immediately. However, when you have bacteremia from CNS or from gram-negatives, you may start doing lock therapy initially. And whereas when you have Staph aureus or Candida species, recommendations are to withdraw to remove the catheter. The Hickman is usually removed, yes, when Candida causes a catheter-related infection. However, in this baby, this was the second Hickman, and this infant was dependent on Hickman because of long-lasting need of total parenteral nutrition. So the central catheter was not immediately removed. That was something, a necessity that could not be done differently. Well, we may use lock therapy. When we do lock therapy, we use antifungal agents that are active against Candida biofilms. And we use antifungals, lipid amphotericin B, echinocandins, and do not use azoles. Azoles do not have any effect on biofilms. So the child switched to therapy with micafungin. The dose was 10 milligrams per kilogram per day, once daily, in order to have also some levels in the CNS. Log therapy with micafungin was initiated. Finally, blood culture became negative 12 days after the initiation of the therapy, and the C-reactive protein dropped. The next question, and the last question, duration of therapy for candidemia and also CNS infection. How long? Any additional tests to undergo? And which is the appropriate follow-up of the infant? So these are also important questions for the continuation of treatment and also the prognosis of this baby. And of course, what is its prognosis? So follow-up and outcome depends on what you have, candidemia only or candidemia and CNS candidiasis. The patient received antifungal therapy for a total of 28 days, 4 weeks. He had an uneventful stay in NICU for the rest of his time. He continues on total parenteral nutrition and he has a colostomy, will be operated later on. And now follow-up, yes. And what is the prognosis? Well, invasive candidiasis in the neonates can cause increased mortality. I showed you some data from Denmark. There is mortality. There's a longer hospital stay. Okay, so this baby stayed. Of course, some babies are small enough that will stay anyway for longer time, but candidemia itself, candidiasis itself, may prolong the time of hospitalization. And also, it may cause problems, especially if it is followed by CNS candidiasis, many disability-adjusted life years, which is a problem for these little babies. Neurodevelopmental impairment, as it has been shown, it is high in fungal infections, mostly candidiasis in neonates, actually higher than gram-negative sepsis or gram-positive sepsis. So it is important to treat invasive candidiasis well in order not to have this kind of difficult sequelae. I think this is my last slide. And thank you very, very much for your attendance.
Thank you so much, Emmanuel, for this overview and this case presentation. I'm sure there will be questions later on. For now, I'm going to hand over to Hannah, who will introduce our second speaker.
Hello, thank you very much. And I apologize for not introducing myself earlier. I'm Tihana Vicinic. I'm an adult infectious diseases specialist at St. George's Hospital in London with an interest in adult mycology. So thank you very much to Emmanuel. Our second speaker is Bill Steinbach from the University of Arkansas College of Medicine. He's the chair of the Department of Pediatrics and the associate dean for child health there, as well as pediatrician-in-chief of the Arkansas Children's Hospital. Bill has a long-standing interest in fungal infections in immunocompromised children, having previously worked at Duke, and he also founded and directs the International Pediatric Fungal Network, which is an NIH-funded global consortium of 55 sites dedicated to investigating pediatric invasive fungal infections. And he also co-founded and co-chairs the biennial conference Advances Against Aspergillosis. Bill is going to present a case to us today of pediatric aspergillosis. Thank you very much, Bill, and over to you.
Thanks, Tihana. Hopefully everyone can see my slides. So I'm going to I'm going to talk in a broader sense about pediatric aspergillosis. And this is a complex disease. It's complex to recognize, it's complex to diagnose, and it's complex to treat. So the interesting thing about this disease is it's the entire spectrum. This is the same organism that can do all these things, that can sort of give you invasive infection all the way to hypersensitive infection. It just depends on the host themselves. But the organisms themselves are different inside the genus. So as you're understanding this from looking at the diagnosis correctly, getting the species level is critically important. As Emmanuel mentioned for candidiasis, the treatments are different. So here we look at some of the resistance patterns that are simply different, and some big ones in bold there that, you know, sometimes empiric therapies will not work based on the types of species that we have. This guidance came out relatively recently looking at how do you diagnose using CT imaging pulmonary aspergillosis. It looks a lot like mucormycosis, and I'll just show you one table right here of ways to sort of separate the two. And people have tried this for years of how does one look different? This is fundamentally important because in some of the guideline recommendations, voriconazole versus amphotericin are very different treatments for these two very different diseases that look very similar. So the diagnosis is not simple. We could talk for hours and hours about the newer molecular methods based on diagnosis, but I want to focus really more on treatment. So let's figure out how do you actually treat aspergillosis. The most referenced guidelines is the Infectious Disease Society of America. These are old. These are from 2016, and those are updated from 2008. There's other guidelines out there. Here's a smattering of guidelines across the globe of looking at different types of aspergillosis guidelines that are all there. And there are all kinds of possibilities here. Looking at various guidelines, you see that voriconazole in most countries, this is some review that Paul Brouet published a while ago, is the preferred recommended treatment for invasive aspergillosis. Lots of previous clinical trials, many of them quite old, right? And we'll talk about some of the more recent ones coming up, and many of them looking at different flavors of amphotericin in different ways. So it's important to interpret how we look at the controlled trials. So the fundamental understanding of the IDSA guidelines is voriconazole is the preferred therapy for invasive aspergillosis. It is for adults, it is for children. Begin it early. Combination therapy, we'll talk about in a little more detail. That's tricky to figure out when to do that. Primary therapy with an echinocandin is not recommended, and there's all kinds of reasons to go into there. And then the question is, how long do you treat, and what else do you do? You of course try to reduce the immunosuppression in an immunosuppressed patient so as to not have the disease take over. Here we have pediatric guidelines that two of our speakers, Adelia and Emmanuel, helped write these guidelines. These are critical and the first guidelines we saw dedicated for children. If you look at the table here, again, voriconazole is the therapy of choice for pediatric patients. Yeah, we can talk about TDM, we can talk about different uses of voriconazole, but compared to the other agents out there, it has the most data for adults and for children. This is another interesting guideline written, and we have one pediatric provider here, Brian Fisher, my colleague, looking at how do you treat aspergillosis in stem cell transplant recipients. And if you follow their guideline recommendations here, voriconazole is again recommended. There are other alternatives, and the question is, what were they on before? So you have to look at the whole patient and figure about what were they on before as prophylaxis? Did that fail? And what are they on now? How is this working out exactly? So you see the last section where they talk about, were you on mold active prophylaxis or not? And of course, we have to examine the resistance levels in the area that you're in. In pediatric patients, specifically here, they're recommending exactly the same thing. There are nuances in that not all of these drugs are approved at all ages in children. So you have to be careful as you're using them. And then, of course, we'll talk about soon about the bioavailability. That's going to be different, and the types of use of the drugs, dosages are going to be different in children. And the last section there talks about the metabolism of voriconazole specifically. So these are some nuances for pediatric patients for treating aspergillosis. So if you look at voriconazole pharmacokinetics, this is an important slide. It shows you how the dosing is different. So for Tihana, as an adult provider, these are very different doses. If you use adult doses in a small child, you will fail. And it is not the agent's fault, it's your fault for using the wrong dose. Look at the bioavailability. While it's much higher in adults, it is much lower in children. It's probably especially important to use higher doses of voriconazole when you have very small children. And then, this happens to be a study looking at children under the age of 3. There are children under the age of 1 that probably need even higher doses. Again, The dosage recommendations I gave you before are nice places to start, but it's a question of how do you follow that particular patient with TDM and whatever approach you want to take to understand how to keep treating them. If you use therapeutic drug monitoring, TDM, what level is important? That's unclear. Most people would say it's between 2 and 5.5. The suggestion is probably 1 microgram per mil is generally greater than the pathogen's MIC. Most people want to probably around 1 or 2, and you'll start to see side effects at the 6th level, something like that. So probably right around there. Every patient is different. There's inter-patient variability. There's intra-patient stability. So your particular patient following therapeutic monitoring will help you figure out that patient. Now, what about isobuconazole? So here's the study that looked at isobuconazole versus voriconazole, and you see how the study was set up over multiple sites in multiple countries, and the 2 agents head-to-head. What you'll see is it's a non-inferiority trial. Isobuconazole should be just as good as voriconazole for treating invasive aspergillosis, and they show you the issues right over here. Fewer adverse events with isobuconazole. You'll see the same thing with posaconazole. Voriconazole is a good drug. It does have lots of side effects, and that's a whole other lecture to talk about what those side effects are. But isobuconazole is not inferior. The way I would summarize this is that it is not inferior. It has less side effects. It does have activity against mucorales. That's a different aspect that voriconazole does not. The current thinking is that isobuconazole does not require TDM. I'm showing you a reference from one of our pediatric college, Area Litzar, when she worked with Pfizer years ago. At one point, it was suggested voriconazole did not need TDM. That's clearly false. So we don't know if in the future we'll have more data to suggest that isobuconazole does need TDM as well. But overall, these 2 drugs are very similar. In pediatric patients, we've only completed a PK study so far. We haven't completed more definitive studies to know how it works in children for treating invasive aspergillosis. Let's look at posaconazole. Here's a head-to-head comparison from one of our colleagues in Belgium looking at posaconazole versus voriconazole for primary treatment. So that's the initial treatment of invasive aspergillosis. This was not a pediatric study. Look at this table right here. Of all the patients involved, 5 were children under the age of 18. Now, the study had yet to be over 13, so some of these were children that were in the 16, 17, 18-year range. That's not really a child. There's always a question of when does a child become an adult, but this is not a dedicated pediatric study. What it did show was the non-inferiority of posaconazole to voriconazole. So you have guidelines that say voriconazole is the best therapy. That is the drug that we have the most data about in children. Then you have adult clinical trials that suggest isobuconazole and posaconazole are probably non-inferior as well. So you have 3 azoles that are good choices to treat invasive aspergillosis. And of course, we're not even discussing the initial amphotericin deoxycholate that Emmanuel mentioned is not really used in anything else besides neonatal candidiasis. That study was done long ago in 2002. So we're going to focus on the azoles as the primary therapy for invasive aspergillosis. What about salvage therapy? Salvage therapy is defined as something went wrong. So you have a lack of response to the agent. In the IDSA, they talk about the important points of it's not always just the drug. First, figure out, do you have the right diagnosis? Lots of CT scans look very similar. Disseminated adenovirus, mucormycosis, something else besides invasive aspergillosis. Check your serum levels for the azole. Do you have enough of the azole? There are plenty of reports of patients with lower TDM, lower trough levels that do have effect. So it's not completely curative that you have to have a level of a trough level above a certain amount in order to be having a positive effect. There are plenty of reports, including clinical trials and including a more recent multi-center trial that looked at TDM management versus just initial dose management that says that maybe the levels don't mean as much as we thought. In general, I personally try to keep the levels high enough to know that at least this agent is at the appropriate level. Because if the patient's metabolizing the drug differently or something else is happening and my level has dropped, then I don't have adequate coverage. This is not very different than a patient with disseminated MRSA and you're treating with vancomycin and the vancomycin level is too low. It's probably your fault and not the vancomycin's fault. Reducing underlying immunosuppression, if feasible. Can you drop the factors that will contribute to the aspergillosis worsening? And of course, if you're lucky enough to have an isolate, any susceptibility testing. These are things to think about when you're in the salvage setting to figure out, what went wrong and how do I treat aspergillosis? Generally, people think you should change the antifungal class, something different, either a different agent or a combination of different agents. Again, it's understanding that if you're on azole prophylaxis or you're on azole in the primary therapy, probably another azole is probably not your best choice. If you're failing voriconazole, I wouldn't simply switch to posaconazole unless the failing is because of the side effects and the inability to get the levels high enough. So in this study, we hear from the group that Adelia had led for the guidelines, they're talking about salvage therapy. Again, you get some ideas that voriconazole is recommended for the naive patients. Otherwise, there's other options over here, and it becomes more complicated if you're looking at salvage therapy. In the HSCT guidelines we saw, what do you do when you have progression on disease? Well, the first thing is infectious disease consult. That's us. Okay, so and look at the things over here. Poor compliance. Is the patient taking the medication appropriately? Understanding in the pediatric world, the bioavailability is so low for oral voriconazole that you have to make sure that the levels are appropriately. The immunosuppression, the looking for azole resistance by doing MICs, super infections. I mean, all these ideas over here. Some work that Paul Verwey did several years ago looked at maybe it depends on the resistance. Do you have a high level of azole resistance in the soil in where you are? If you have minimal resistance, here's where he's suggesting, well, use voriconazole. If you're azole resistant, that's where you take on a different path. If you are beginning with an environment where there is high azole resistance, that's different. Voriconazole by itself would not make sense in that situation. What does high risk mean? Generally, 10% is what we use in clinical medicine if something is high risk, a higher likelihood of having that in the area. So here we're talking about azole resistance of Aspergillus isolates from the soil. What about combination antifungal therapy? This is confusing. So the guidelines from the Infectious Disease Society of America changed. And you look at the words matter that I've underlined in 2008 and 2016. Not recommended and may be considered. Those are both weak statements, but they're showing the shift in saying that, well, maybe combination therapy would work. This retrospective study done almost 20 years ago now is what prompted some of the main work to look at combination therapy. And most importantly, in the graph, looked at that at 90 days, you only had 10 patients in each arm that you were comparing to and saying, hey, the combination group is higher. And if you look at the editorial later on, from a year later, you actually only had 8 patients. 7 were in one group, and 1 is in combination. So at that time, at a year, there's really no difference. So at this retrospective look of voriconazole plus caspofungin, while people wanted combination therapy to be more impressive and to be functional, because we see that in other aspects of medicine, it's not really clear. This prompted, of course, the voriconazole and nidulafungin RCT combination study. Well designed. Voriconazole nidulafungin upfront and voriconazole versus placebo, and you see the specific design points over there. In the primary analysis, really wasn't any difference. Did not achieve the pre-specified threshold for statistical superiority. So maybe it was designed as a superior trial, not a non-inferiority trial. If you looked a little bit closer at other things, you see that the mortality endpoints favor the combination, but the global responses favored the monotherapy. It's a little confusing. If you go further down in there and look at the galactomannan work, the mortality was lowest for those with combination therapy in the patients that had probable invasive aspergillosis based on galactomannan. Perhaps this is the most important part. Perhaps these are the patients we see more likely that you have probable aspergillosis based on a CT scan and a galactomannan, and you're sort of starting therapy early. So again, in all diseases, whether we're talking about colon cancer or invasive aspergillosis, you can't compare therapy A to therapy B if they're begun at different times. It's more important to get the disease treated early. In malignancy therapy, if you catch cancer at stage 1 versus stage 4, those are vastly different outcomes. So maybe this is the indirect evidence here that really it's important to catch this so early. So that's the way I would look at this, is that there's some sub-analyses that's showing different things, but combination therapy might work. I've used it sometimes, but not all the time. And then I'm going to end right now with the International Pediatric Fungal Network that Tihana mentioned that we run. There's 55 sites throughout the world studying pediatric disease. We've had multiple major multi-center studies. This was one of our first studies. It was an NIH grant. It was an antifungal study, and it was published over here looking at comparative effectiveness for invasive candidiasis. So really trying to mainstream the work that in children that we do that is not always reflected in the RCTs and in adult patients. The second NIH grant we had looked at biomarkers for diagnosing candidemia. It was actually the largest fungal biomarker study in any age group ever performed, and it was published right over here in CID to look at biomarkers and what works best for candidiasis, looking at some of the newer studies. Two other grants that we have that are ongoing studies right now is an invasive mold study, looking in patients that have CT findings of invasive mold disease and how do we manage them. That's a complex disease to figure out. And a fourth, more recent grant that we just begun, a study that's just begun, is looking at duration of therapy in children with candidemia. Can we take children that have uncomplicated candidemia, patients that otherwise would generally do well, and can we randomize them to giving them 7 or 14 days? In other words, if we treat them with the echinocandins, the guideline-approved therapy for candidemia, can we give them less than the full 14 days of therapy if they've already cleared their bloodstream? And I'll end that and be happy to take any questions along with my friend Emmanuel. Thank you.
Thanks, Bill. I was waiting for Johanna to start off, but great overview. Really interesting. I'm sure there will be follow-up questions. I have at least one, because this great biomarker study for candidemia in children, can you maybe just as a start off of the discussion, can you allude to the main findings there? What did it tell us? Are the tools we are using in adults as valuable as in children, or do we need to be a little bit more considerate about some of those tests?
We looked at multiple biomarkers for candidemia. So these were patients in the ICU generally that had risk for candidiasis, and you're at the inflection point of saying something's wrong with this child, sort of like Emmanuel's case. Do I begin antibacterials? Do I begin antifungals? Do I begin both? And we evaluated the patients at that time and drew serum for biomarkers, and then what happened with the patients. In essence, what we found is that the T2 biomarker was the most helpful in children, and the beta-glucan biomarker was not very helpful at all. We also did analyses looking at combinations, because you could imagine a world where, well, do I have increased sensitivity if I get a beta-glucan and a T2 and a Candida PCR, and the T2 was the one that sort of shifted out as something that seems reasonable. That's the biomarker we're using in this other study, looking at the duration, because that's a critical point. So most clinicians, when you say, hey, I'd like to treat candidemia for only 7 days, they're going to have a myocardial infarction, the clinician. So we have to figure out a way to say, okay, are there patients that need 14 days, and are there patients that need 7 days? As we know, in infectious diseases, there's a trend toward less therapy, pick a disease, tuberculosis or anything else, and not more therapy. Can we give better and less therapy in a smaller period of time? And we're trying to figure out, do we have patients that have candidemia, treat on an echinocandin, and then their blood culture becomes negative, and then we draw a T2 biomarker to help us confirm that, like, yes, this is negative. They might be ones that we could use 7 days versus 14 days in the future. So it was an interesting study, and of course, with the International Pediatric Fungal Network, these types of studies require multi-center collaboration, because these diseases are relatively rare, and it's frankly more fun to work with your friends.
Absolutely. Okay, thanks, Bill. Maybe to follow up, there is a question in the Q&A list. I'm going to start off with your thoughts, Emmanuel. Maybe, Bill, you can start up, follow up on that. It's a question from, sorry, I need my reading glasses nowadays, Maria Amalia Copdelcado, saying you recommend the use of beta-glucans for diagnostics of invasive mycosis in pediatric patients. And I would like to hear both your opinion on the use of beta-glucan for candidiasis versus aspergillosis or mold infections, as well as is there any age differences within the pediatric patient group?
Well, I may start. Yes, the value of beta-glucan has been quite established in adults. However, in pediatrics is not. And this study, the study which Bill mentioned, P study, actually found that, I would say unexpectedly, that with such a high number of patients, that it was not so much valuable as it was T2 and Candida antigen antibody. So the problem with just a comment on T2 Candida may not is not so much disseminated. So hospitals may not have T2 Candida to run the test. So beta-glucan in children has not been proved very helpful. Also, the cutoff value is not quite defined. However, in neonates, there are a number of studies, and actually that particular meta-analysis looked at all these studies, and there might be a difference there. It might be of some value in neonatal candidiasis. Sensitivity, specificity around 80% or so might be okay for such a case. Why this happens? Why not in older children and in neonates? I don't know. Might be the pathogenesis of candidiasis might be somewhat different in neonates than in older children. Maybe the load of candida is much higher in neonates than in older children. I don't know, but looks like that there is a difference there, age-specific difference that in neonates might be helpful, not in older children so much helpful. So that's my understanding of what is happening in the arena of beta-glucan. I don't know, Bill, you have any?
Yeah, as Emmanuel mentioned, we wanted beta-glucan to be successful. We put that in our trial to understand a biomarker, and it mathematically simply wasn't. It wasn't that useful. In practice, beta-glucan for me is a wonderful way to diagnose pneumocystis. That's a great way to do it. It's also helpful in the ICU when you're sort of wondering. In other words, if you have an ICU critically ill patient and the beta, where there's all types of confounders, right? All types of things in the ICU that can be false positive for beta-glucan. If the beta-glucan is 0, if it is negative, you can probably with pretty good certainty suggest the patient does not have a fungal infection. But if it's positive, you don't know why it's positive. It could be any number of things, one of which is a fungal infection. So it has a great negative predictive value in that sense, but it doesn't really help me to say it's definitely a fungal infection. So it has a value, and I don't use it the way the manufacturer would like me to use it, but that's where in practice it actually makes some sense.
Okay, so moving on to, do you mind, Delia, if I ask the second question? Yeah. So there are two questions around the theme of antifungals and penetration into the CNS. So the first one from Dr. Ng, I always thought echinocandin does not penetrate CSF, but your talk indicates that mycofungin does. Is that right? And then Dr. Zavalza saying, pretty interesting case. The guidelines, should the guidelines change to using echinocandins instead of liposomal ampho, or is more evidence required? What are your thoughts on that, Emmanuel?
Well, Dr. NG is quite right. I mean, echinocandins are big molecules and they have a difficulty to go through the brain barrier, the blood-brain barrier, and go into the CNS. However, we use very high doses. In those high doses of 10 milligram per kilogram, even actually 15 milligram per kilogram have been used, as compared to 2 to 4 milligram per kilogram, which we use for treating a candidemia case, which is almost 3 times higher dose. We achieve some concentration in the CNS. Also, you may think that these areas of candidiasis, all the infections are inflammatory areas. So they have a lot of inflammation, they have a lot of not disrupted blood-brain barrier. But mostly the very high doses of mycophenolate are the ones which we take advantage of, and we use it for CNS. This has not been studied or done with the other echinocandins. Anidulafungin, for example, is not used at all in neonates, in patients less than 1 month of age. And caspofungin has been used, but has not been studied for this kind of infection. So mycophenolate is the only one which is recommended. And that's why, responding to the second question, yes, the recommendations do contain also liposomal amphotericin B. Liposomal amphotericin among all the 3 amphotericin B, deoxycholate amphotericin, ABLC, amphotericin B lipid complex, and liposomal. Liposomal is the one which penetrates better in the CNS, and this has been studied both in animals, in rabbits, for example, and also this is something that can be used. So liposomal amphotericin B is recommended, can be used, but mycophenolate also in very high dose, like 10 milligram per kilogram up to 15 milligram per kilogram, the first day especially, is also recommended.
Some of what Emmanuel is talking about is related to some older animal studies that did show that in the CSF, the echinocandin was not as penetrating in the CSF, but in the animals, in the brain, in the tissue, there was enough echinocandin there. In reality, the disease is in the tissue and not the CSF. So I think that's an artifact of the initial animal studies that developed that thinking.
I agree indeed. I'm always saying to our trainees that, we think of the CNS as one compartment, but indeed, there's the brain and then there's the CSF. And actually, if you look at amphotericin B penetration into the CSF, it's very low, and yet we use it to treat cryptococcal meningitis, neonatal candidiasis. Okay, well, I have a question that came up. Well, I have questions for both of you, but for Emmanuel, first of all, as an adult doctor, I'm curious to know, why is it that when babies or neonates get candidemia, that it seeds to the brain, but it doesn't in children and adults? Why is that?
Very good question. As you exactly said, invasive, candidiasis, CNS candidiasis is found only in neonates and maybe in some kind of immunocompromised patients like the CART9 deficient patients, but not any adults or even older children. Why is that? I don't think that this is very well explained. Maybe the tissue, the way, the barrier between the tissues, the blood-brain barrier, or maybe the load of the candida, which is higher in neonates. I don't think that it is very well understood, but definitely this is something which is very important, and it's well known. But I don't think that there is any other explanation. I don't know if Bill or Adelia think of anything else, but yeah, that's that's most of my response.
It's something that's been shown in autopsies, but I don't think the mechanism's been figured out as to exactly why. We just see far more disseminated disease in neonates.
Yeah, I mean, there was a study of leukemia patients with CNS candidiasis, but that was so few, very few, so few that almost not happening.
There's another question that somebody's asked in regards to beta-D-glucan. So, Bill, you alluded to its excellent negative predictive value, and indeed in adults, that's also, I've just been thinking recently a lot about how we use it in our critical care ICU population. in terms of algorithms. How, you know, if you are writing guidelines for children for suspected invasive candidiasis or neonates, how do you incorporate beta-D-glucan? What's its role in for use in empiric prescribing and stewardship at your institutions?
That's a complex question, and again, lots of studies and lots of guidelines have tried to make beta-glucan be an effective biomarker, and I'm not sure it is in children. People have alluded to the basic idea of what's the cutoff value. I mean, that's a simple question. If you're using a quantitative biomarker, is what is the inflection point for positive versus negative? And that seems to be more confusing in children. And then, of course, the word children is confusing because a neonate and a 4-year-old and a 14-year-old are not the same patient population. So that's confusing. I mentioned the ICU thing that I've used my own self is understanding, hey, this has negative predictive value. I don't know if it's as high as in the adult world. I don't think that study's ever been done. There's been lots of ICU, Candidiasis, even Aspergillosis studies done in the adult literature that suggests about negative predictive value, but it's not been really done well in pediatrics. So I am hesitant to use beta-glucan as a definitive biomarker in children, period. I would never use it only. I would never only use that one tool because I'd be worried about it. But in the setting of other things that suggest there's no invasive fungal infection in an ICU patient, and I have a very negative beta-glucan, then I have a more confidence. But I wouldn't use the beta-glucan only by itself.
That is my impression as well. I mean, not by itself, but as an additional test, maybe when you have a big suspicion for candidiasis, invasive candidiasis in a neonate, and you have an increased beta-glucan, it might increase. How much increased? That's also a problem. Bill alluded on that. I mean, what is the cutoff? Probably more than 120. Yeah, you may think more about the.
And the practicality is sometimes the test comes back greater than 500. Well, I don't know what that means. That sounds like cross-reactivity to me.
Right.
Yeah, maybe just good to add in this discussion, we have recently sampled premature babies and sampled them the first 6 weeks of their life, and we measured beta-D-glucan. And none of them had invasive candidiasis. And we saw a lot of positives. I mean, not overly positive, but above, in between the 120 and 200. So we definitely need to look for a better cutoff to make this test of better use in pediatrics. And I'm not relying on it as a test. I mean, there needs to be more than beta-D-glucan, either positive or negative. Yeah, and I'm not sure the greater than 500, does that tell us there's a lot of candida? I mean, I don't know. I mean, like you were saying, Bill, sometimes I think, oh, maybe then there is something, but still we don't know.
We have some more questions around drug treatment and dosing. So Deborah Palacios asks about dosing of voriconazole in infants less than 2 years. Would you recommend giving voriconazole 3 times a day or giving a higher than 9 mg per kilogram dose? That's, I think, to you, Bill.
They're both good options. They've each been tried. The therapeutic drug monitoring is probably pretty important. I happen to view that. It's something as simple as getting a trough level is not easy. I have seen people get trough levels inappropriately where they're literally drawing the value from the line that is infusing the voriconazole, so it comes back way too high. Or someone will say, hey, the next dose is due at 3 p.m. I'm going to get the trough level, I'm just going to get it at 130 and not 259. And then if you have inconsistent trough levels because a nurse drew it at different times, you make inconsistent strategic decisions. So even something simple as how do you get a trough level is important so you can accurately analyze the data. and then use those trough levels to guide. For me, the 9 per kilo per dose is a good starting point. Most children, especially an infant under 2, as Deborah's mentioning here, really require higher doses. And in fact, sometimes I'll begin at that level, and I'll even empirically go up once I see that I don't have an overt toxicity in the beginning, because I know it's going to have to be higher. And I don't want to wait several weeks in a complicated stem cell transplant patient while I'm waiting to see if the voriconazole works, just to know that my dose is too low. It's probably going to be too low. This is far better than the old approach of starting much, much lower, but oftentimes it goes high. The side effects are reversible. So if you overshoot and you have to go back, the side effects are reversible. If you take too long to get to the right dose, the patient could die.
Of course, we have just to say, I mean, all these are very correct, that voriconazole is not usually recommended less than two years, unless there is a specific reason and, we use it off-label. So I think the recommendation is less, it's not to be used in less than 2 years of age.
Emmanuel, there's a question for you about your case. Somebody, Harshani Thabru, says they had a very similar case recently. They didn't have mycofungin. They had to remove the line. Is there any place for amphotericin B lock therapy for these type of babies? With
Sure. Yeah, I mentioned lock therapy can be done with either liposomal amphotericin B, but the oxycholate amphotericin B is also active against biofilms. Not so much maybe as liposomal amphotericin, but it is active. And echinocandins, micafungin. We should not use azole. Azole is not, even in very high concentrations, we have used that in the lab, in vitro, with biofilms, Candida biofilms, and azoles are not active against biofilms. As we know that the catheter, Candida creates biofilms on the catheter. So if the catheter cannot be removed for some reason, there are reasons. I mean, this baby, which I mentioned, that was the second catheter that he had, and that was dependent on Hickman catheter because of total parenteral nutrition, because of the short gut syndrome. We can use amphotericin B. We can use amphotericin B. If we do have liposomal amphotericin B. If we don't have liposomal amphotericin B, we can use the deoxycholate amphotericin B for lock therapy. The thing is that we have to keep, the problem is that if the catheter is 1 lumen catheter, it's sometimes difficult because we have to keep lock in there for definitely more than 2-4 hours. So maybe the baby cannot afford this time of closed catheter because of total parenteral nutrition, of fluids, of other things. That's the problem. So, but if we have a 2 lumen catheter, that's much easier.
Thank you very much.
The interesting comment in the chat from, and a very helpful one from Andy Borman, who is co-director of the Mycology Reference Lab here in Bristol in the UK. And he gets a lot of requests to analyze samples for beta-D-glucan. And he is using back titration. And they have data that in proven candidemias, levels are up to 1,500, 2,000 picogram per mil. So they can go up quite high.
I think that's a great point. And we see the same thing with galactomannan. And at one point, I have seen galactomannans as high as 8, something like that. And I've seen them in a patient that died. So clearly in overwhelming invasive aspergillosis, galactomannan is 8, makes sense, autopsy, riddled with disease. Another patient who's smiling at me, whose galactomannan is 8. And it's clearly some sort of cross-reactivity of something else. So I like the titration idea. I like Andy's approach. It's a question of, I have definitely seen times where it's like this patient doesn't have candidemia at all, but their beta-glucan is really, really high from some cross-reactivity. So again, it's an interesting tool. I just would not use it as the only tool.
Okay. There are coming more and more questions in the chat. This is also an interesting one about antifungal prophylaxis in premature babies, or I think it's in premature babies. In settings where Candida auris colonization and invasive Candida infections are high, so around 5 to 10% in neonatal units, yeah, so premature babies. What would be a reasonable antifungal prophylaxis regime in those kind of situations? Or, and that's my kind of addition to the question, should we not use antifungal prophylaxis in those situations? Emmanuel.
Right. I mean, you definitely have to increase your level of infection control and prevention. You know, all the measures that we usually have to take. Also, you know, to use less antibiotics. There are some kind of, you know, antibiotic stewardship in neonates. If it is totally entirely necessary to use an antifungal, in this situation, as we know, Candida auris is almost universally resistant to fluconazole. So we can't use fluconazole prophylaxis. Some people have recommended mycofungin, but you know, this is you know, candidas are usually active still in many places of the world on Candida auris, or maybe nystatin. Yeah. However, nystatin needs a baby to be fed orally. I mean, cannot be given intravenously. So it cannot be given in a very, very premature baby, which is not does not tolerate food. It has to be fed in order to be given. So those are the two options. I mean, either nystatin in an orally fed baby, or mycofungin, you know, which is not, of course, desirable totally, but if it has to be given something.
Yeah, I agree. I would favor nystatin above mycofungin from some personal communications with colleagues across the world, where they changed to mycofungin prophylaxis because of these reasons. It was just a short time, and there was a lot of echinocandin resistance coming up. So yeah, we really need to consider this carefully, what to do, and not to replace one resistance with the other. Yeah. Okay.
Thank you.
I think there is a question for you too, Hannah.
Yeah, there is, although I will throw some of it. I'm going to incorporate some of my thoughts back to Bill as well on this around TDM. I mean, clearly, Bill, you really emphasized the importance of TDM, and of course, Eunice, hello, Eunice. It's really important in adults and children, and yes, absolutely, I always use TDM for voriconazole, and it is recommended for treatment of any kind of aspergillosis. And I agree with Bill that I tend to monitor it more than once, and we know that there's both intra and interpatient huge variability. And clearly, and I've learned something today about how it's even more variable in children, and I hadn't realized the bioavailability was so much poorer. So my question to you, Bill, regarding combination therapy, you presented the evidence, but should we not, given that voriconazole based on clinical trials, and let's remember there's never been a comparison of liposomal amphotericin with voriconazole head-to-head in a randomized trial, hence why we use Vori, because it's got the best evidence. But given this pharmacokinetic variability in adults and even more in children, and the results of the Kieran Marr study indicating quite a significant difference in survival, should we not be using combination therapy initially until such time that we know that the child or the adult has a therapeutic level, which we all know takes time and they're very sick?
There are studies that have shown exactly that, Diana, in that it makes sense that, you know, in this case, you could do voriconazole plus mycofungin as an echinocandin choice, and say, well, at least I have one agent that's effective, the mycofungin, although head-to-head not as effective as the azole, while the azole is potentially sort of increasing. The other way, so there are people that suggest that, and that makes sense. That makes mechanistic sense. Another thing to do is, as you're beginning the voriconazole, then also make sure that you sort of increase it swiftly. Like I said, I sometimes will wait for a couple days to make sure there's not an obvious overwhelming side effect. You don't have massive hepatic issues or anything else. And then I'll increase it again even before I get the level, because I know it's going to have to be higher. And luckily, if I overshoot, I can safely drop it back down. And then all that in the TDM question of, there are examples, and there's even a more recent Dutch study that I saw, a multi-center study with 10 centers, where the TDM approach versus standard dosing had no difference in outcome. If you look closely at Raoul Ehrbrecht's study from 2002, there were patients that, if you looked at some of the sub-analyses, that had levels that were almost undetectable, that were successes with voriconazole. It's not different than your amphotericin idea before of, hey, the CSF fluid concentration is so incredibly small, yet the patient gets better who has meningitis. So it is confusing, but even with that confusion, it makes sense to most of us that we would want to have an appropriate level of the drug to take that variable out. And I use the vancomycin analogy as a story of, if your vancomycin trough is way too low and the patient's dying of MRSA septicemia, you probably have an issue with the vancomycin not being high enough. So I like to push it high enough, and then I do have to tell people it is important you understand how you get those levels, because I've seen levels inappropriately obtained and people make decisions based on things that are not consistent and accurate. And classically, it's a timing issue where it's not really a trough level, and someone thinks the level is actually too high because they drew it 2 hours early. They think of your curve, and then they drop the dose, and then it's really low when you check it for real the next time.
So, and just to follow on from that, you mentioned that you should always see what's been before, which of course is very sensible in this era of increasing azole resistance, both in Candida, as we've talked about, and in Aspergillus. So what if a patient who's been on posaconazole prophylaxis develops invasive aspergillosis? Are you still happy to use voriconazole monotherapy in that context?
In that case, I would not. Yeah, I would not personally. But even with the posaconazole, there's the thought that the TDM for posaconazole has sort of two levels, of one for prophylaxis and one for treatment. So one thing I'd want to make sure of, what does breakthrough mean? If the patient's breaking through on posaconazole, but I have a level and the posaconazole level is undetectable, then the patient wasn't really on posaconazole. So breakthrough might not be the same. In that case, an appropriate amount of azole, potentially even posaconazole, could work just fine. But if the posaconazole level was appropriate and they broke through, then yes, I would switch to something else. And classically, have you seen, I would treat it almost like the azole resistance algorithm that Paul Verwey had done, where it would be probably ambisome plus an echinocandid. But I would not try another azole there. And above all, whenever you can, if you are lucky enough to have an actual isolate, send it to the laboratory, get the susceptibility testing, because you can't predict everything exactly just based on epidemiology.
Thank you.
Okay, thanks. I think the questions in the chat have been answered. I think it's time to wrap up. Do you agree, Tihana?
Yeah,
I think we had a fantastic discussion and two fantastic presentations giving us an overview and an update on the treatment of neonatal candidiasis and pediatric aspergillosis, and the many challenges we still face, as Bill was saying, difficult to diagnose, difficult to recognize, and difficult to treat. And that's, I think, for the clinicians on this call, what we all face in our clinical practice. But thanks so much, Emmanuel and Bill, for making the time to share your knowledge on this topic with us all. Thanks, Tihana, my co-chair, for stepping in to chair this session about pediatric fungal infections, and hope to see you next time.
Yeah, I think Tihana, even as an adult provider, did a great job.
thank you.
Okay. You in Athens for the team meeting.
Yeah, see you there.
Bye.
Thanks.
Bye.
Bye.
Bye. Bye.